Hi, it's Dr. Centeno, and we are live here at You've Got the Power. Today, we're going to talk about an interesting topic. We'll be talking about tinnitus and how it relates to cervical instability, craniocervical instability, the neck in general. And it's interesting because, for many, many years, we didn't really know what caused tinnitus. Now there are a bunch of theories about what causes tinnitus. And some of those theories overlap with the neck. So we're going to get into that today. As usual, I'll spend some time just giving a short didactic lecture. This one's a little longer. It might last 10 minutes or so. And then after that, we'll get into Q&A. You can ask questions about this topic or really any topic at all. And the goal here is just to get patient questions answered, to make sure that patients understand which end is up with all this stuff, whether it's on this topic or what's bothering them about orthobiologics, about craniocervical instability, whatever that is. It's my experience that an educated patient does better than a patient who doesn't really understand what's wrong. So that's why I do this twice a week at this point, trying to see if I can shed some light on things for patients. I know we all live in this world where doctors just don't spend a lot of time with us. And the doctor might blow in, look at some things, do a short exam, and then go out. And many patients feel like they're not getting their questions answered. So that's why I'm here. So let's talk about tinnitus again. We're going to talk about tinnitus and the neck and what's going on with all of that. Let me share the screen here. And once I share the screen, then I'll start with a short presentation, and then we'll go to questions after that. So it looks like that worked just fine. And we'll go to some slides here. And here we go. So what causes tinnitus is what we're going to be talking about today. And this is really part of a larger series I'm going to do, and that is focusing on various symptoms that CCI patients have, and then going through and trying to dissect that topic a little more. So tinnitus would be one, brain fog is another, headaches is another, dizziness and balance, and kind of take it from the symptom side and then go back from there. So you let me know if this is a good format or not. So tinnitus is a ringing sound. Now that's to be differentiated from pulsatile tinnitus, which is this rhythmic whooshing, thumping, or throbbing in one or both ears. So they're different from each other, right? Tinnitus is a ringing or a buzzing, sort of constant sound. It might go up and down slightly. It's usually much, much worse when you don't hear much around you, meaning in silent situations or low sound situations. Pulsatile tinnitus is this rhythmic whooshing, thumping that sounds vascular. So we'll start with just tinnitus, and then we'll go to pulsatile tinnitus. So possible causes of tinnitus. There's lots of different ones out there. There are at least two that have to do with this dorsal cochlea nucleus, or the DCN. But the one I'm going to talk about today is this somatosensory hypothesis. And that is stimulation of non-auditory structures. So everything else here involves the ear or the inner ear. But this one really involves the neck. So somatosensory tinnitus. So one of the things that's different about this kind of tinnitus is that this often changes its loudness, pitch, or localization, meaning where it's coming from in the room, when there's stimulation of the head or neck. So that's one of the things that makes this type different. And again, the origin seems to be in the head and neck, meaning you can treat the head and neck sometimes, and this will go away or get temporarily better. Now, realize that there's these two different pathways. I'm not on my super big computer screen today, so the pen should work. There's this otic pathway, which is all about the inner ear, right? We've got the cochlea, cranial nerve 8. And again, as I said, heavy involvement of this dorsal cochlear nucleus. But then we've got the somatic pathway, and that's the head or neck that we were talking about here. And now we've got cranial nerves 5, 7, 9, and 10. I'm sure those sound familiar to people. And the C2 spinal nerve. And then those are connecting to this medullary somatosensory nucleus. It lives in the medulla. We've talked a lot about cervical medullary syndrome, right? Pressure on the medulla from the dens. And that's supposed to be inhibiting the dorsal cochlear nucleus. But when these things don't inhibit that, you start to get this tinnitus sound. So cranial nerves, these are cranial nerves that would be familiar to many CCI patients. The fifth cranial nerve, trigeminal, the facial nerve, glossopharyngeal nerve, and vagus nerve. So these are the nerves that are suspected because they jack into these systems. Now, the C2 spinal nerve is another one that you would be familiar with, because if we look at the C1, C2 joint, right? This is C1 here. This is C2. This is the back of the joint this way. And in the back of the C1, C2 joint lives the dorsal root ganglion of C2. So if you've got too much motion happening at C1, C2, you can beat up on that C2 dorsal root ganglion. That's going to give you some headache pain, but it could also cause tinnitus. And that would get irritated in different types of instability, but heavily irritated in that instability type 2B, or that lateral C1, C2 overhang, or excessive C1, C2 rotation type of CCI. So now we're going to switch gears and talk a little bit about pulsatile tinnitus. So we're leaving sort of the constant ringing, and in this somatosensory tinnitus, the constant ringing that maybe changes its pitch or loudness with head movement. Now we're going to go to pulsatile tinnitus, which is that whoosh, whoosh, or thump, thump, thump type tinnitus, a different kind. And pulsatile tinnitus sounds like someone's listening to a vessel. So the most common venous cause is intracranial hypertension, and that's something that would be familiar to many of the watchers of this program, because that's not uncommon in some of our CCI patients. There are other cardiovascular causes as well, however, that should be ruled out. So these include carotid artery stenosis. This is usually on one side. So that's the carotid artery that runs through here. Uncontrolled blood pressure can be a cause as well. So we can't just jump to conclusions and say all pulsatile tinnitus is linked to CCI. Other things are going to have to be ruled out too. But if we're talking about intracranial hypertension, one of those mechanisms we've discussed is you've got the internal jugular vein, IJV here, right? And then you've got the transverse process of C1 and the transverse process of C2, which can put pressure on that internal jugular vein, and that can back up the outflow of the blood flow from the brain, or increase the intracranial hypertension, or intracranial pressure, causing intracranial hypertension. So just realize that there are things that can happen in the upper cervical spine that connect here. Now, when it comes to internal jugular vein compression, internal jugular vein compression, these are the most common symptoms. So we have here tinnitus is right in there. Head noises would be that pulsatile tinnitus. So tinnitus and pulsatile tinnitus are right in there as the biggest complaints. Insomnia is there, but there are a lot of things that cause insomnia, so that's not so specific. Hearing impairment, well, if you're hearing head noises and tinnitus, you're not going to hear real well. And then headache, which is one that would be more common in our CCI patients. So if we look at these, really tinnitus plus headache would be one that would be very specific for something like CCI, or would raise the likelihood that CCI might be the cause, obviously other causes as well. Now, we need to be careful when we're talking about internal jugular vein compression, because we have these studies that show that there's a lot of patients walking around with moderate stenosis, severe stenosis, even bilateral severe stenosis, who have no symptoms. So be careful here, because just because someone says that your internal jugular vein is compressed because they took a quick ultrasound or maybe they looked on a CT venogram, doesn't mean that that's causing your symptoms, because there's a lot of people walking around that have compression and no symptoms. So let's pause and let that sink in. More than 1 in 4 normal patients has a moderately compressed internal jugular vein. About 1 in 5 normal patients has a severely compressed internal jugular vein. About 1 in 10 had severe bilateral internal jugular vein stenosis. And these are people who don't have any symptoms. So as far as treatment is concerned, really, if you have CCI and tinnitus, then the goal is to treat the instability. And the other big thing is to make sure the other more common causes have been ruled out. Things like uncontrolled blood pressure, carotid stenosis, hearing issues that are occurring within the inner ear, etc. So let me go to questions and see if we've got questions out there. Looks like we got some. So we'll go to those. I don't know how to pronounce that, THM. How long does it take for traumatic lanoaxial instability to resolve on its own? Well, like any instability, if it's going to heal, so it would be no different for this area than it would be for your ankle, right? If you stretch the ankle ligaments while you're playing basketball, obviously different issues there, right? One's ankle pain, the other is all these other symptoms associated with CCI, but same concept. So if you stretch those, you get about 4 to 6 weeks for it to complain. And then by 2 months to 3 months, depending on your age, it should have healed completely. So if you're in that 3 to 6 month range, then there's a real doubt as to whether or not it's going to heal on its own. And if you're in that 6 month plus range, there's a lot of doubt. Now, one of the things that could possibly help that is to see an upper cervical chiropractor, try to get it in place, keep it in place, and see if that results in a better position, causing better healing. Virginia, it's been advanced by Clint. Have you done any videos or Facebook Lives on thoracic outlet syndrome? Yeah, I have. If you just go to the YouTube page under Lives and just search under thoracic outlet, you'll see stuff come up there. Rishi, last week asked a question about if it was useful to get an upright flexion extension MRI along with DMX. You said it was 1 in 20 chance to get a change treatment plan. Correct me if I'm wrong, but as far as I know, DMX only indicates ligaments are lax, and an upright flexion extension MRI would indicate things like muscle atrophy, arthritis, brainstem, spinal cord compression, disc bulges, etc. Just trying to understand why in most cases it wouldn't change the plan, as it seems like. So to answer what I have there so far, Rishi, we were talking about craniocervical instability. So when it comes to craniocervical instability, what I can detect on a DMX would be if there is a type 2B, which would be the most common one we see. I can also detect if there's a type 2A, where there's an increase in lanodental interspace, and detect if there's a type 3A and 3B. Those are the 3 most common types of instability we see. Now, if you have hypermobility, then I think there's a higher chance that we'll see some abnormalities on a functional MRI with flexion extension, where we can see things like a collapsing clavoaxial angle or a type 1A instability, or we can see things like a type 1C where there's movement between the skull and the neck. But if you don't have hypermobility, it's unlikely that getting that flexion extension MRI is going to change the clinical picture of what it is we're going to do. Now, it may add another type of CCI there, but the question is that going to move the needle on what we do for that person and how we do it? And the answer is probably not. So about 1 in 20 is right. Now, listen, as I said last week, if you want to get both, I welcome reviewing both. And there are certain patients where it's not clear enough on the DMX. Well, we'll recommend getting an additional set of imaging through an upright flexion extension MRI. Or there are patients where I think it's not clear that we're dealing with CCI based on their history. So we'll get both studies just to make sure we're absolutely covering all bases. I also have patients where they can't afford both, where they have to make that choice. Or if they do both, they're not going to be able to afford to get it treated. So if they ask me, I tell them the DMX is more likely to show it if it's present. Rishi, if a patient has upper neck inflammation, muscle atrophy in the neck due to CCI, is it advisable to exercise the neck or do nothing? I'm not sure what to do, as I don't want to make my CCI worse by exercising my neck. There's also know it's not good to do nothing and live a sedentary lifestyle either. I feel bad when doing nothing and feel the same when I exercise my neck. With temporary stability, walking helps stabilize and lessen some symptoms. Yeah, so I just answered this question for another patient just recently here, just today when I was seeing telemedicine visits. The real goal here is to see how you respond. So if how you respond is you do something, let's say it's going out for a walk, and that puts you down for 3 days, that is not a net positive. But if you can go out and do a walk and it's not a problem and it kind of helps or maybe doesn't really make it any worse, then go do the walk. Same thing. If you can go out and lift light weights or do light exercise and it puts you down for 3 days, not a good idea. If all it does is doesn't really change all that much, then go do it. So those are the kinds of things you need to think about. It's more the patient's response than a hard or fast rule. We have patients who can do light to moderate exercise with CCI. We also have patients that a walk around the block will put them down for 3 weeks. So realize that this patient population is so varied that the exercise prescription, if you will, has got to be very specific to that person. THM, would the tinnitus resolving indicate that atlantoaxial instability may resolve? It's certainly a good sign. It could also mean that some of those nerves that were getting irritated aren't getting irritated anymore. It also could be that the body has adapted to the decreased inhibition of the dorsal cochlear nucleus. So hard to say, but I would take it as a positive sign personally. Leslie, doctor, please help. I have instability of 7.1 only on the right side after an accident, but I see blurry in right side, tinnitus, right side where I was fine, scared of a stroke. I think I'm not quite sure what you would mean instability of 7.1. So if you're talking about C1, C2 overhang to the right at 7.1 and you're concerned about a stroke, I wouldn't be concerned about a stroke, even though it's possible and your chances may be raised. You need to realize that at the end of the day, in my larger 1,000 or so CCI patients that I see, I've only had one patient in that patient population who had a minor TIA from a vertebral artery dissection. So we don't see that frequently. Now, what would I avoid? I would certainly avoid any long lever head manipulations done by regular chiropractors. That's to be differentiated from NUCA and AO chiropractic, which aren't like that. I would certainly avoid contact sports, those sorts of things. But I don't know that I would live in fear of a stroke because it would be a very, very rare event, even in a CCI patient. Some advanced by DB. Can acupuncture help with a mild case of CCI? Never seen it help with a mild case of CCI, but a lot would depend on the kind of CCI and the severity of the CCI. Maybe if you had some mild, for example, type 3A/B, where you're getting some sliding of C2 on C3, and that was causing some irritation of the C2-3 joint, and that was causing local spasm, and those upper cervical muscles weren't stabilizing anymore, and you did some deep dry needling in there to get rid of the muscle spasm at 2-3. In that case, you might see some results. Manuela, from your experience, what would be the approach to stop C2 from rotating? What ligaments hold C2? That would be the alar ligaments. So the alar ligaments help to stabilize C1, C2 in rotation and in side bending. So those are the alar ligaments. Now, there are other accessory ligaments that are involved as well, but the alars are the prime stabilizers there. It's been advanced by Sherry Scott. Many people I know from Facebook group for CCI seem to have tinnitus. Are they related? Yes, as I've said here, Sherry, the two are likely related. We see a lot of the tinnitus complaints go away or calm down when treating the CCI. So I believe they're related. Now, again, as I've said, there are other causes of tinnitus. So we always have to be cautious to make sure that all those other things are ruled out before we blame it on the neck. AT, when dealing with muscle tension post-PICL with stiffness and pain, what is your opinion on massage therapy? Is there a specific form you'd recommend? You know, I think my CCI patients would be split on massage therapy. Some would state that it would make them worse. Why does it make them worse? Because they need that tightness, and that tightness is what's the only thing holding their upper neck together. Others would say they get some relief from it, meaning they may get relief of headaches because the muscles are pinching on the occipital nerves. I would say you want to see a massage therapist that's going to do massage in this area without moving your head and neck around a lot. So they're going to be stabilizing your head while they're doing their work back here. And a massage therapist that understands you have instability. So if there's any increase in any concerning symptoms, nausea, vomiting, substantial visual changes, slurring, etc., that person knows to back off immediately and not go there. Sean, can scoliosis cause tinnitus or vagus nerve compression? Well, as I've said here before, and Sean, if you go to the YouTube channel and look under the lives and search scoliosis, you'll see that I've done talks about this before, that any side bend in the spine is always accompanied by rotation. So those are coupled movements. So if you've got a side bend in the spine, you're going to get a rotation at C1, C2, and that can cause these kinds of CCI type symptoms. That can also lead to vagus nerve irritation or compression. Susan, higher Centeno primary care doctors and even some neurologists seem to doubt that CCI even exists, even though they don't have another explanation. Your opinion, why is the main health systems are resistant to this diagnosis and treatment? Well, I think you can look no further than just look at the surgeons, right? We've got 5 surgeons, maybe 6 in the entire world that do 70% of these cases, meaning elective treatment of craniocervical instability when the head's not fallen off. So that shows you how little expertise is out there. Why is there little expertise out there? Primarily because this stuff isn't taught in any residency training program. So doctors go through medical school, but then they do their specialty training. They do internship, then they do a specialty training, and then a subspecialty training many times. And if this isn't taught in those programs, then it's going to go right over the doctor's head. So it's not taught in neurology programs. It's not taught in interventional spine fellowships. It's not taught in physical medicine rehab residencies. It's not taught in spine surgery surgery residencies and spine surgery fellowships, etc. So it's just a matter of education. Now, One of the reasons why I put together the typing system, and I've been so vocal about this online, and giving lectures several times a year to healthcare professionals, including physicians, is to try to raise awareness that this is out there. And that's the way, regrettably, it's going to have to come in. It's going to have to first come in the back door before it gets in the front door, so to speak. Regenics been advanced by Gerald Frost. Is CCI more common in men or women, or is it about equal? Yeah, I would say that we have slightly more women than men, but a lot of that is probably because of our EDS patient population that have CCI. If we were to take the EDSers out of it, meaning more women have EDS, it's probably pretty evenly split. Robert, can you speak of why there's an increase in tinnitus after AO treatment? Yeah, I don't think that would be across the board, or at least that's not something I've heard. Now, for any specific individual, it's possible that after an AO treatment, immediately afterwards, you may get some irritation of one of those nerves we talked about, the C2 spinal nerve, cranial nerve 10, 5, 9, etc. So that certainly could happen in any individual patient, but that's not a complaint I hear a lot of from patients. Strange. Happy September, Dr. C. Yeah, happy September 1st. My birthday is September 6th, so that's coming up. When can we safely take NSAIDs, especially aspirin, after a PICL? Yeah, it's not so much safely, meaning you could safely do it tomorrow, but the big issue, I think, is trying to stay off enough of that stuff for long enough so that you don't blunt the initial inflammatory response, which we kind of need in tissue repair. Now, that initial inflammatory response is only lasting sort of 1 to 3 weeks. So if you wanted to get back on as quickly as possible, it would be at that 3-4 week mark. If you wanted to be super safe, probably wait to 6 weeks. So that's kind of how you should do that. But it's really making sure you don't blunt that acute inflammatory response, which is so important for tissue healing. AT, the culture expanded cells in Cayman Islands, what's your opinion on how much increased success that would look like with PICL versus BMC? I don't think we'll ever know, because I don't think PICL will ever be offered down there. The biggest concern with doing PICL in Caymans is that because it's a small Caribbean island, they've got excellent first world everything down there, including a first world nice little hospital, a new one called Health City. But the problem is that they don't have the medical infrastructure of the United States. It's not possible on a small Caribbean island, no matter how fancy it is. So that's been my biggest concern, and the reason why I don't think we'll ever see PICL done in Grand Cayman, simply because the medical intensive care infrastructure isn't there. Now, have we had a PICL patient end up in the ICU? We have not. But at the same time, I don't want my first one to be in a situation where the best ICU is called Miami, meaning I don't want a life flight involved or something like that. So the good news is we haven't had to use that system, but the bad news is I still want to feel comfortable that if we were to need that system is all around us here in Colorado. Multiple hospitals, multiple ERs, multiple chances and opportunities if you need to get checked out at 2 in the morning because something weird's going on. And we've had a couple of patients who have done that. It's turned out to be nothing. But, it's good to be able to just walk down the street or drive down the street and go to an open emergency room. And if that one's not open or too busy, there's 3 more just past it. That just doesn't happen in a small Caribbean island. John, hi, Centeno. What are the differentiating factors when diagnosing someone with CCS rather than cervical instability? Yeah, John, the big difference is instability. When we talk about CCI, most of the symptoms are generating because of the problems in the high upper neck. So then for craniocervical syndrome, that's what it is, right? It's something in the high upper neck which is causing those upper cervical symptoms. If we add instability to that, then we've got craniocervical instability. We pick up a few more symptoms, things like increased head pressure due to pressure on the internal jugular vein, those sorts of things. But for the most part, the symptoms are pretty much identical. The only difference between the two is one's got instability and the other one doesn't. Regenics, been advanced by Harry Winston. I had a bad case of COVID recently. My CCI seems to have got much worse with this. By what mechanism could COVID affect CCI? Yeah, I don't see any mechanism where the two could be related at all. Now, I think what patients may find, and it's not just COVID, it's been every infectious disease since typhoid fever back in the Civil War, that we know that there's an increased inflammatory response. For instance, we've known since the Civil War that if someone has a big infection, blood clot incidence or prevalence increases. So, while the media would have you believe all these things are brand new, they're not. They've been going on for 150 years or 200 years or more, or at least we've known about them. So in any infection like that, you're going to see an increase in inflammatory markers. Now, if you're heavy set and have metabolic syndrome, high blood pressure, heavy set, high triglycerides, poor blood sugar control, that inflammatory experience you have with COVID or the flu, it doesn't really make a difference what it is going to be much more intense. So you may have seen more inflammation happening, and that could have caused, let's say, a nerve here that was mostly pissed off and just wasn't yet fully clinically present, meaning it hadn't been pushed over the edge to get pushed over the edge. But I don't think we're seeing ligament damage from COVID. I don't think we have any evidence of that at this point. And we've known about inflammatory responses to viral and other type of bacterial illnesses forever. These are not new topics. They're 200-year-old topics. John, foam rolling my thoracic spine put pressure on my dorsal scapular nerve that caused a lot of neck symptoms like tightness and irritation. My C5, 6, 7 bulge, are these connected somehow? I mean, dorsoscapular nerve wouldn't be one that generally refers to the neck. I think there what may have happened is doing a little bit too much to try to get rid of the kyphosis too quickly, meaning your body has to adapt to that, and that could certainly piss off the neck for sure. Patty, how to manage headaches 3 months after occipital concussion and whiplash injury, and what would you recommend for treatment options? CTP contrast showed normal results. Yeah, Patty, I can't give medical advice over the internet with sort of scant details about what's going on, so can't really help you there. Maya, can pulsatile tinnitus be caused by muscle tightness? Wherever my muscles are tight because of C2 hernia disc, it gets worse. Sleeping with towel on your neck makes it better. Is it possible that it could be caused by muscle tightness? It is. It would be less common, though. It would be more commonly related to other types of issues and things, as we talked about pressure on the internal jugular vein or a non-neck cause at all. Stenosis in the carotid artery, that kind of stuff. Levon, if CCI is treated but cervical curve isn't on point, can tinnitus or pulsatile tinnitus still be a problem? Yeah, I think you're bringing up a good point here, and that is that you're really talking about the proximity of the C1 and C2 transverse processes to the internal jugular vein. So if you've lost your curve, that's going to close that distance. If you get the curve back, that's going to increase that distance from those transverse processes to the internal jugular vein. So the curve status could also be involved for sure. John, understanding every case is different, but if you injected someone 6-7 for a bulging disc causing nerve irritation, ideally, how long would you tell that person not to work out with weights, pull-ups, bench press, etc.? We really don't restrict that at all. Now, it depends on what got injected. If we're talking about the disc, that might be a different story. We might tell that person to back off for a week or two. But if all we're talking about is epidural or around the nerves there with something like platelet lysate, that's an activity as tolerated procedure. So they're not told to specifically restrict, but to avoid things that bother the area. Amber, what is carotid stenosis? Does CCI cause tinnitus? And then also here, heartbeat pumping when laying on ear. This is what I have. Carotid stenosis is the carotid arteries in the neck can get plaques, just like the arteries around the heart. And that reduces the diameter of the artery, and then that causes a whooshing type sound, something you can hear with a stethoscope. So you could probably even hear it if you put your ear there. If you had someone else put their ear on your neck, they'd be able to hear a whoosh, whoosh, whoosh right here. So that'd be one quick way to try to see that. Obviously, you should see a doctor and they can check that out too. But again, as I've talked about here, there seems to be a connection between CCI and tinnitus through those mechanisms that I discussed before. Bo, how important is it to have my MRI during my consultation with you? All I currently have is my DMX report. I definitely don't need your MRI report. If you have your MRI images, that would be very helpful, meaning that we can't clear you to do something like a PICL procedure until we have a cervical MRI showing that there are no potential bad things that we would want to miss. So I would definitely make sure, I don't really need the report, but I do need the images to review for sure. Jesus, for TMJ, how many shots on each side? If you mean number of rounds, usually just 1 to 2. If you mean number of physical shots, that depends on what it is we're treating in the TMJ. If we're treating the most common, which would be the joint and the capsular ligaments, then that's 2 or 3 injections per site or per side there. 2 or 3 sites per site. Russian, your clinic, do you find BMAC or BMC to have more powerful treatment than PRP for ligament dysfunction? We do, for sure. Kimberly, because they do what they can make money at, it's all about Medicare guidelines and following their approved criteria. I think you're talking about the CCI stuff. Robert, can you comment on how many treatments of consistent AO or nuclear treatments without result should one seek regenerative? I find many patients have to stick with the process for many, many months. Yeah, Robert, I'm much more conservative on that. I really think, and probably this is where you're headed, is that we should try to keep it pretty limited. If you're not seeing results in that first 4 to 6 weeks, I don't think you're probably going to see longer term results. Now, this is one of those things where I may have AO or nuclear chiropractors disagree with me, but in my general experience, that's what I see. So that's what I'll generally tell my patients is give it a good college try, but if it's not for you, it's not for you. Bo, what is the percentage of patients do you recommend surgery versus PICL? What is the qualifications for surgery? Yeah, Bo, so when it comes to surgery, the qualifications are going to be a severe structural abnormality. So for instance, for example, one that comes to mind is the DENS that is so dramatically indenting the medulla that it's causing a big indent in the structure. So that's someone I'm just going to tell to go have surgery. Or a patient who obviously has an upper cervical fracture, that's not something that we can deal with. Or a patient who has severe increase in the atlantodental interspace in flexion, meaning it's going into the 6 to 8 range. That's someone where we'll get a surgical consult. Or somebody who has a cystic structure in the upper cervical spine. We've seen that a few times. Or someone who has absence of upper cervical ligaments. We've seen that in a few congenital malformations of the upper cervical spine where there won't be a posterior arch and the ligaments are malformed. And the patient was born that way, and then they get in some sort of minor trauma and things go crazy. On the percentage basis, the good news is that's not a high percentage of the patients we see. Now, obviously, there may be more patients out there, but they're probably self-selecting into surgeries before they're coming to see me. So for my current Surgical rate is probably 1 to 5%, depending on the month. And that's probably because, again, these patients are getting heavily filtered, meaning that they're getting plucked out of the system. If they've got a fracture, we're operating on that for sure. Or if they've got severe indentation of the dens into the medulla, that's when we're operating on, etc. Mike, for a disc bulge in the cervical and thoracic area is just 2 shots of PRP, 1 in each area. Oh God, Mike, that would depend on what's going on. Is that disc bulge causing symptoms? Is it not causing symptoms? Meaning that I would say about 50 to 60% of all disc bulges that are out there in someone, let's say my age, don't cause any symptoms at all. So I'd need to know a lot more than that. Could you briefly explain COX versus LOX and how anti-inflammatory supplements don't inhibit healing inflammation, but NSAIDs do? Yeah, my biggest concern with blocking the acute inflammation is the COX pathway, and that's what's blocked by NSAIDs, whereas things like fish oil block the LOX or the lipooxygenase pathway versus the cyclooxygenase pathway. But long story short is, one is more critical for that acute inflammatory response, and the other one is less critical. So, but having said that, this is a good chance to bring this up. One of the things that we do see is many of our patients are taking high-dose fish oil, which is great. It's a great way to manage inflammation. But at the same time, that can cause some thinning of the blood and excessive bleeding during a procedure like PICL. So we want them to be off of that for a week before they do that procedure. So I'm just using that as an entree there. I try to say that one as many times as I possibly can. Robert, are there finance options for patients needing PICL? Not through us. Now, there's always finance options available through financing companies, but we leave that between the patient and those companies. We're not good at assessing financial risk, and not something I want to get involved in, meaning assessing financial risk. Opinion on functional neurology after PICL for TBI was completely ineffective prior, but would it make a difference doing it now after ligaments are healing to help treat neurologic symptoms? Sure. I think giving it another shot, if you're feeling better, that would be the operative difference, would be reasonable. Russia, I got an MRI 2 years after I injured my lower back, and my MRI shows a disc tear with atrophy of the multifidus. Will I be able to gain muscle in area through physical therapy? Yeah, it's a very good question. It's one no one knows the answer to yet. I think that you can certainly help it and increase your overall spinal stability by doing core type physical therapy. What we don't know yet for sure is if that atrophy can be reversed with physical therapy alone. So that's still an open question. Susan, I had a very scary experience. I felt a pulling sensation on my eyeballs inward toward my head. Lost focus for about 5 seconds. Could this be from CCI? It's possible, Susan, but I would need to know more. I'd probably need to know the patient more. So best I could tell you is it's possible. John, is there any natural way to take pressure off the IJV other than PRP or stem cells? Well, as I think we've talked about, if you can tolerate curve restoration, that's a good way to go. NUCA or AO also can do it too. So those are the kind of things that I'd recommend to try to take pressure off the IJV if you've got upper cervical stuff going on due to the IJV. Edward, are there any CCI specialists in Asia, Singapore maybe? None that I know of, no. We've got a CCI surgeon in Barcelona, a Dr. Gillette, but no CCI specialist in Asia of which I'm aware. Caleb, if someone has posterior instability only, do the shaping of the 0-1 joint to prevent the alar ligaments from getting overloaded, basically buying time to get those posterior structures treated. Certainly if you've got normally shaped 0-1s, which is that shallow, this is upside down, guys, because I can't move my hands like that, but skull 1 That's going to assist the ligaments. If you've got flattened 0-1s, then that's going to put more pressure on the ligaments. So that's about all you can say about those two different conditions. AT, would taking a turmeric supplement in addition with stem cell formula would be harmful? Yeah, there's a lot of turmeric in the regenerative stem cell formula, so I wouldn't add to it personally. Maya, does having a Swirls hernia hurt? I have mid-back pain, especially when standing for longer. Walking uphill and vertebra hurts to touch. I'm already showing you small. Yeah, I think you mean a Swirls node where the disc has herniated through the end plate. It is believed that that's a non-painful thing. Now, it doesn't mean it can't cause pain. It doesn't mean that there isn't something else going on at that level due to the herniation of the disc upwards that's causing pain. Centeno, 2.5 months past PICL2. Excited for the next visit to have more improvement. Thank you for your work. Oh, thanks, Aaron. Always happy to get an update and just keep plowing through. So thank you for the update. Bo, what is your vision for your practice to make PICL more available? Why is it not taught in traditional medicine? Yeah, Bo, I think we've gone through that a little bit here, but I'll say it again because I know I've said it in past lives. It's my intention to train several selected physicians in how to do PICL before I retire. Now, the problem is that's not trivial, and it's not trivial for a number of reasons. The first reason is I would want that person to invest in a clean room for processing the cells. Well, that's $1 million US investment. So the number of practices that are going to sign up to do that are few and far between because of that huge investment. That doctor would also have to have dual C-arms. So that's in their office. So each C-arm is going to be about $130,000 US. That doctor would have to have an endoscope. So that's going to be another $70,000 to $80,000 US investment. And then from there, that doctor's got to have advanced upper cervical injection skills through fluoroscopy. So they really have had to have done a lot of 0-1 injections, 1-2 injections using fluoroscopy, contrast, and digital subtraction angiography. So now we're down to an even smaller pool. Now we're down to a tiny, tiny pool. And then that doctor has to want to deal with me for 3 to 9 months or 12 months or however long it takes to get highly skilled in doing this, but not only doing the procedure, get highly skilled in knowing how to manage this very challenging patient population who comes at this from huge differences in function. Like I said, I've got people over here, they can work out. And as long as they don't do certain things, they're fine. I've got patients over here who can't get out of bed. So that is a learned skill set that takes a while to learn and understand. Because what I don't want to do is to educate someone how to do this, and then all the patients that can't get out of bed just get marginalized because that doctor doesn't want to deal with those harder to deal with patients, or the patients that have multiple areas to treat don't get those treated because that doctor doesn't want to deal with that. He just wants to focus on the simple, easy ones, et cetera. So it's not trivial, and it's something I think about often, but that is what my intention is at this point. Levon, will THC or CBD affect initial inflammatory response to post-PICL? Unlikely to affect the initial inflammatory response, but again, we don't know how those things impact. Stem cells are healing. In addition to that, just realize that they do impact anesthesia requirements in a very negative way. So it's one of the reasons why we try to get people off of that stuff before they have a procedure. Regenetics been advanced by Julia Smith. Are there foods or food categories that would help to avoid the CCI? Yeah, Dr. Pitts on our Regenetics website has an excellent book, Nutrition 2.0. I would read that book. Sharon, hi, Dr. Centeno. Thank you for doing this again. It's really helpful. Do you see any differences in results in patients who got AO treatment versus patients who didn't get AO? Not really, but I do think what we see is those patients with AO where it really helps them temporarily, they've got a better support system than the patients without. And what I mean by that is, for instance, if they get really flared up from a procedure, they know what they're doing. They're going to go see their AO, they're going to put back in place, and boom, that's calmed down. So, it's something to definitely consider prior to doing this, is trying AO or nuclear chiropractic. See if it's the right thing for you. If you get good temporary relief, then you've got that support system to fall back on. And that's, I think, the big difference that I see is that having someone out there who can do something conservative and kind of make you feel better. Nisa, 8 weeks post, is it common for the neck to feel very loose? The bell curve suggests this. I'm also having tinnitus. Seems louder at times and not at others. Is this common to have symptoms coming and going like this? Yeah, Nisa. So remember we talk about, and I think maybe what you're referring to here is you've got that initial anywhere from 1 to 3 weeks of a honeymoon effect where things are tighter. Well, then that's due to inflammation. Then the inflammation goes away. So during that time, I call it the donut hole, things are going to feel looser because they were tighter artificially, and now they're going back more to normal. And then after that, in the 3 to 4 month range, we're getting tissue remodeling. So then that generally goes back up the other side. Russian, how much is an in-person or telehealth consult for CCI? I believe it's $275 that gets applied to your procedure, but don't quote me on that. Amber, does tinnitus caused by CCI erect similarly to traditional tinnitus? I ask because I do notice my tinnitus changes with the amount of sodium I eat, and my tinnitus began when my atlas occiput subluxed. Yeah, I'm not an expert in how sodium impacts tinnitus. Now, what you could be describing is tinnitus related to internal jugular vein issues and intracranial hypertension. So what would make sense to me would be that if you that could be sodium related, meaning increasing or decreasing total blood and fluid volume. Obviously, if you've got more fluid volume, you'd have more tinnitus because you've had more intracranial hypertension. If you've got less fluid volume, then less. And then obviously the atlas rotation could put pressure on the internal jugular vein and would also be a modifying factor. Bo, without solving the underlying issue with CCI, can you recommend any supplements, foods, or diets that can help preparing for PICL? Yeah, so the supplements would be those Regenix supplements that we normally recommend prior to a bone marrow concentrate procedure. And then the diets would be going on to the Regenix website, downloading Dr. Pitt's book, Nutrition 2.0. Mark, I saw a video you did on cultured stem cells in Grand Cayman from 6 years ago. An FDA trial was mentioned. The status of the FDA trial, do you think cultured stem cells will ever be available in the U.S.? Yeah, so that particular FDA trial is in phase 2. It's recruiting probably halfway through its recruitment period. That's my guess. I haven't talked to those guys in a while. That technology was licensed out. COVID was a huge donut hole for all clinical trials, meaning obviously pretty much all of them came to a halt for 2 years there. So all of that is now 2 years behind, whether it's that or anything else, where it would have been otherwise. But they're, don't quote me, but about halfway through recruiting their phase 2 clinical trial. Sharon, hi, Dr. Centeno. You treated me with the early Regenix stem cells for AVN in the early 2000s. Hey, Sharon. I had a whiplash accident last December and have stenosis in several disc areas. Listening to this seems like CCI might be what's going on. I'm experiencing all the symptoms that you're describing. CCI affect your echocannabinoid system. The symptoms seem to line up with function. I wouldn't say that, but certainly, Sharon, if you're local, come on in and we can certainly take a look to see if your exam localizes to the upper neck or localizes to those areas of stenosis. Now, Sharon, we're doing a follow-up on all of those initially treated 2005 to 2007 patients. So if you're in that 2005 to 2007, it looks like you're not. I was going to say you may want to contact us for follow-up, but it doesn't look like you're in that group. So anyway, if you're local, I would say come on in, and happy to take a look. Nisa, if you do cortisone shots in the body, it's going to affect PICL stem cell inflammation healing. Yeah, if you're doing traditional cortisone shots where it's a milligram dose or 1,000,000 times physiologic, which is the most common type, that could certainly affect PICL healing. Now, if we're talking about low dose, which is nanogram dose, which is more in tune with what the body would use, no, it's not going to impact that at all. Hazmat, are tears inherent with lax ligaments, or can lax ligaments be lax and not have any tears? Yeah, it depends on how we define tear. If we're defining tear in the surgical sense, then we're talking about a ligament that is torn and pulled back to two halves like a rubber band. But if we're talking about tears in their much more common presentation, we're talking about micro or small partial tears in the ligament, where the ligament's still intact but just lax. And that's what we're talking about with these sorts of injuries. Maya, what are the symptoms of muscle atrophy? Well, if you mean the deep stabilizing muscle atrophy, that's going to be instability at that level, which can cause pain at that level. So for example, multifidus atrophy in the low back, for example, is most commonly associated with back pain or leg pain even more commonly. And then I'm going to have to start wrapping this up because I have a 2 p.m. Meeting I have to get to, and it's 1:56 my time here. Caleb, in response to Rush Patel's question about atrophy, jamilities has shown that fatty infiltration can be reversed in cervical multifidus. Study done 1 in 5 chronic whiplash patients. Haven't seen that one, Caleb, so send me that one. Happy to take a look at it, but that would be great news for sure. Forever, hi, what imaging that are showing sliding instability to the one joint facet? That would be more flexion extension upright MRI. I have a lot of difficulty sleeping. Yeah, I think it's definitely a good idea to get on a very regular sleep schedule, go to sleep at the same time every night. You may want to take melatonin at the same time every night and wake up at the same time every morning. That would be the way to go. Amber, I have a tongue tie, an increased forward head posture. I've hesitated with the tie release, feeling it could further cause instability. I echoed that same concern. I knew it was best and not have the release, be able to safely have a tongue tie. Yeah, I think you're more likely to be successful if you have CCI, if you get that CCI treated. John, Chiro tells me my atlas is out almost every time I go. Is that a sign of CCI? It could be, for sure. Just realize that we have certain metrics that we look at to see if someone has craniocervical instability. Okay, guys, well, I'm going to start wrapping this up. We've been talking about tinnitus. Seems like a lot of interest in this CCI symptom series, so I'll start doing more of these. And that means that, doing one on headache and all the different causes with CCI, doing one on tinnitus, doing one on gut problems, etc. So I think we'll do more of these, and because we had a lot of engagement and interest today. Thank you for all the great questions. Again, we all learn by asking questions, getting our questions answered. And one of the things I feel very strongly about is trying to make sure that patients have a forum to get their questions answered. Because as I said before, all too often these days, you go in and see the doctor, you get to ask 1 or 2 questions, and then that's it. Or maybe you're then assigned to a nurse practitioner or a staff member who tries to answer your questions. So the goal is to get questions answered. So you all have a great weekend. I will be here on Monday, and we'll have another topic. Maybe I'll do another one of these symptom series. So thanks so much, and have a great weekend out there.